important topic. Postpartum hemorrhage can come as a short note, it can come as a long note, or even, of course, you'll never get it as a case for obvious reasons, but then when you have again your evening viva, table viva, your afternoon viva, they will definitely ask you one question on postpartum hemorrhage. So today's class is probably the most important topic from your obstetrics. Okay, so we'll be defining what postpartum hemorrhage is. We'll look at the incidence, the types, causes, treatment, and then your prevention. So what is postpartum hemorrhage? So it is defined as blood loss of more than 500 ml following your vaginal delivery, or more than 1000 ml or 1 liter after a C-section. Okay, so if a woman were to have a delivery and this is the quantification of your blood loss is more than these values, then she's said to have PPH. Or even if the blood loss is not up to the set amount, but the blood loss results in more than 10% drop in hematocrit, that you'll find out by doing your lab investigations, or the patient is in such a state that she needs blood transfusion, or she's hemodynamically unstable. What do you mean when you say a patient's hemodynamically unstable? Her heart rate increases, her pulse rate increases, her respiratory rate increases, there's decrease in her blood pressure and oxygen saturation. So when you have any of these components, and even though the blood loss is not up to the values given, you'd still consider it to be postpartum hemorrhage. Okay, so this is very, very important. So what is the incidence of postpartum hemorrhage? So in India, the maternal mortality, these are the main causes of maternal mortality in India. And even if you look at it worldwide, the causes are similar, especially when you compare the causes with other developing countries. So as you can see from this diagram, severe hemorrhage accounts for 25% of your maternal deaths, 25%. Okay, so that is a big chunk, which is why I'm telling you PPH is the number one, the leading cause of maternal death in India. Okay, which is why it is such an important topic, right? And the thing about PPH is that even though it's an important and the most common direct cause of maternal mortality, it is also a very preventable cause of maternal deaths, okay, which is why it's very important. So 25% of maternal deaths, okay, in India is because of your PPH. So that is how common it is. So when we look at types of PPH, depending on the time or duration, we have something known as your primary or your early postpartum hemorrhage. This occurs in the 24 hours following delivery, and it is the more common of the two. And secondary postpartum hemorrhage, otherwise known as your late postpartum hemorrhage, this occurs after 24 hours of delivery, which is more rare. So in secondary postpartum hemorrhage, it could be because of your delayed infection, or maybe if someone has done a C-section and the sutures have given way. So all those come under secondary postpartum hemorrhage. Okay, in today's class we'll be mostly concentrating about the first type, the primary postpartum hemorrhage, which is also known as early, and it occurs within 24 hours following delivery. This is a very, very important slide. From today's class, there are 2 or 3 slides. If you remember them, you're good to go. Up to your final exams, you're good to go, okay? So when we talk about causes of PPH, you just remember what are the 4 T's of PPH, okay? So sometimes in your exams, in your short notes, they can just write what are 4 T's of PPH. So the 4 T's will denote thrombin, tissue, tone, and trauma, right? So these are the causes of PPH. Thrombin, if there's any derangement in your coagulation profile, as you can see in your preeclampsia and abruptio, in your sepsis or pyrexia in labor and other bleeding disorders, that will come under thrombin. So the first T is your thrombin, second is tissue. Now what happens is that if a patient delivers and their products of conception, it can be your placenta or your retained products of conception which are retained inside, this can hamper the proper contraction and involution of the uterus, and this can further lead to postpartum hemorrhage. The third one, which is the most common, is tone. So when a patient has PPH because of some problem in the tone of the uterus, then what that particular PPH is called is atonic PPH. Okay, so again, causes would be obviously over this tension of the uterus, like you can see in multiple pregnancy, polyhydramnios macrosomia. So what happens is that the more distended the uterus is, the more pressure, the more work needs to be done to again bring it back to its contracted state. You get it? The more distended, the more work, the more force needs into getting it back into its normal tone. So any over distension of the uterus in twins, triplet pregnancy, polyhydramnios meaning when there's a lot of LICA, okay, or macrosomia meaning in big babies, okay. So all these factors lead to a decrease in tone of the uterus, and this can lead to something which is known as atonic PPH. So again, uterine relaxants. Sometimes we give uterine relaxants, and this can further, for obvious reasons, hamper the tone of the uterus and can lead to PPH. History of previous PPH is also very important, okay. And then another thing that comes here also is high order pregnancy. If a patient were to be pregnant with her first baby, the chance of her developing atonic PPH is very less as compared to a patient who is pregnant with a fourth or fifth or sixth child, okay? So higher order pregnancy is also a very important predisposing factor. Trauma. Trauma means any trauma to the genital tract. It could be a C-section. So if a C-section is not done properly and there's extension of the incision line, this can lead to traumatic PPH. Why? I'll come to it a bit later. Episiotomy is what you give to a patient when she were to undergo a normal delivery, and extension of the episiotomy or wrong method of application of episiotomy can lead to something called traumatic PPH. Again, macrosomia, anything more than 4 kgs can lead to traumatic PPH if the baby's weight is more than 4 kgs. And what is very important here, I have not included, is instrumental deliveries. So traumatic PPH is more common in instrumental vaginal deliveries. If we were to apply forceps or ventouse in patients, the chances of wear and tear of the genital tract is more, and if this is not controlled, it can lead to traumatic PPH, okay? And the others, these are the other predisposing factors, but what's important for you is to remember your 4 T's. If you remember this, you're good to go, okay? So as we can see, out of the 4 T's, the most common cause of your PPH is your tone or your uterine atony. So if a patient were to have PPH because of a defect in the tonicity of the uterus, we call that atonic PPH, and that accounts for 70%. The major chunk of PPH is atonic PPH. Silgrak Marak, Abhijit Kar, had taken a class, I think this is for your semester. We spoke about ruptured uterus, which is more common in patients who've already had a C-section before, right? So when we talk about traumatic PPH, it accounts for 20%. Tissue or retained products, like I said, retained placenta, retained products of conception, this accounts for 10% of your total PPH. And your thrombin or coagulopathy, this is seen in very less, just 1% of cases. Now, mind you, even though here it's clearly demarcated, more often than not, tonic and traumatic PPH can coexist, okay? If a patient has uterine atony, what happens is that there's a trauma. Suppose she's had uterine rupture, it was not repaired on time, then the uterus will not have adequate time or adequate pressure to come back to its normal tone. So a traumatic PPH can also be associated with your atonic PPH, okay? But out of all these, the most common is your atonic PPH, which accounts for 70% of your PPH. So if you were to write your exams, your MCQ exams, they can ask all of the following are causes of PPH except. So they may add like a 50. So you should know what your 40s are. As soon as you remember these, you can just add up the causes. Tone, you already understand. Any patient has multiple pregnancy or higher order pregnancy. Trauma, it can be because of your C-section or because of your instrumental deliveries or because of your episiotomy. Tissue, any retained products, be it your products of conception, or it could be a placenta, thrombin. Any of the coagulopathy disorders can lead to your thrombin disorders, and that can in turn lead to thrombin causes of postpartum hemorrhage. So it's very important to remember your 4Ts. So we'll look at how the basic difference between atonic and traumatic PPH, because these are the two most common types of PPH. In atonic, the bleeding, there's gushes of dark clotted blood as compared to your traumatic, which is continuous and bright red. The uterus in atonic, because of lack of tonicity, it's larger, bogey, and deficient contractions, which is why it is called atonic PPH. In your traumatic, it is small, hard, and well contracted. Okay, if the rupture is diagnosed on time, and if the laparotomy is being done immediately, if you leave it like that for hours and hours, again, this type of PPH can then lead to atonic PPH. So when you compress the uterus in atonic PPH, gushes or clots of blood come out. Why? This is because there's lack of tonicity, so there's a lot of blood collecting inside. As opposed to your traumatic PPH, there's no effect. Even if you were to compress the uterus, there's no effect that comes out. So when you explore the genital tract, in case of atonic PPH, bleeding, what kind of bleeding? Dark clotted blood is seen coming through the cervical canal, and no lacerations are detected. In case of a traumatic PPH, if you do an exploratory of your genital tract, especially in a patient with a history of instrumental delivery, you will see bleeding coming from laceration in the genital tract. Okay, so these are the basic differences. So when we talk about tone, we'll talk about the first cause, tone, which accounts for 70% of your PPH. So lack of uterine tone, also known as uterine atony, and this kind of PPH is called what? Atonic PPH. What happens to the uterus? Soft, spongy, and boggy, and there's slow and steady loss of blood. It'll just not come out like that, a gush of blood. There's slow and steady loss of blood. So now what happens is that your myometrium, or the muscular part of the uterus, as you know, the uterus is made of 3 parts. Okay, so the middle part, or the middle layer, or the myometrium, which is the muscular layer, has smooth muscles. Now contractions of these, okay, will clamp shut the placental arteries, and this causes reduced bleeding. Now what happens in your atonic PPH? This contraction doesn't happen. Why? Because the uterus has lost its tonicity for various reasons. Like I said, in case of multiple pregnancy, in any case, in any condition where there's hyperdistension of the uterus, such cases will be more predisposed to developing atonic PPH. And this is the reason why, because your myometrium, the smooth muscles, are not able to contract properly and clamp your placental arteries, and because of that, there's excessive bleeding. This is your tonicity. The causes, like I said, repeated distension. Just remember, any distension, it could be from multiple pregnancies, okay? It can be because of your twins or triplets. Muscle fatigue from delivery. This is very important, especially in cases of obstructed labor. Now, for some reason, the baby is stuck, okay? It could be because of macrosomia. It could be because the pelvis is inadequate. What happens is that the uterus is trying to push this baby out, but the baby is not coming out. There's some form of obstruction. And because of that, there's muscle fatigue, okay? So because of that, this will lead to overdistension of the uterus, and this in turn will lead to uterine atony. Inability to empty bladder. What happens is that when the bladder is not emptied, this pushes on the uterus. This is a question which is very commonly asked in your exams. Especially your old school examiners will ask you, what is the importance of emptying the bladder prior to delivery? Okay, this is the reason why. So when you conduct a normal vaginal delivery, or be it a C-section, we should always evacuate the bladder. The reason being that first, it's easier for us to take out the baby when the bladder is emptied, and secondly, this is why. If a patient were to have a full bladder post-delivery, what happens is that this will hamper the contraction of the uterus, because it pushes on the uterus, and this can further lead to PPH. So such a simple reason to have PPH, right? So simple things like emptying the bladder is so important in case of your deliveries. So obstetric medications like your anesthetics and your various medications, your tocolytics, magnesium sulfate, nifedipine, terbutaline, all these are types of tocolytic. When I talk about tocolytic, I'm saying muscle relaxant. So if a patient were to have muscle relaxant prior to delivery for whatever reason, maybe she was a preterm, she had gone to preterm labor, and the obstetrician had decided to, okay, give her tocolytic so that we can give her steroid cover during that time. Now, because of these medications, it can predispose the patient to having atonic PPH. Okay, so these are the causes. So this is your first T. Your second T is trauma. Like I said, damage to your genital structures. Uterus can be damaged. So during a C-section, if the incision is not properly given or while the delivery technique is not proper, while delivering the baby, the incision site can get extended on either ends and this can lead to damage of the uterus. Cervix, vagina, and perineum. So again, incision of a C-section, what happens that if the incision is not properly given, what can happen is that during delivery of the baby, especially in difficult C-sections, cervix, the incision can extend down to the cervix and this can again lead to traumatic PPH. Vagina and perineum, this is usually during vaginal deliveries, especially during instrumental deliveries. When if an obstetrician were to use forceps or ventouse, the chances of, and because of improper technique, or sometimes what happens if we have postgrads who are really not well versed with using your instruments, what happens is that even before the cervix is fully dilated, because of poor judgment, they put a ventouse in and they pull the not fully dilated cervix, and this can again lead to, so that is there. So again, if it's a big baby, any microsomia, definition of microsomia is 4 kgs. Okay, but maybe for your Indian guidelines, would like to take a lower cutoff. So from medical instruments, so forceps, vacuum, and even episiotomy. If an episiotomy, the routine dictum is to give a mediolateral episiotomy. Now, if episiotomy is median, that can actually go right through and then it can extend to the surrounding structures. Okay, and hematoma, what happens is that when there's traumatic PPH, sometimes what happens that if you were to do a per speculum examination, everything looks fine, the lower genital tract, but there's a hematoma higher up. And why does that happen? Okay, this is why. So when we talk about postpartum hemorrhage, when we look at the uterus and its blood supply, the uterus is a very, very, very vascular organ, very highly vascular. Why? For obvious reasons. It has to accommodate pregnancy, it has to do so many functions. So it's a very richly vascularized organ. And you can see here, what happens is that even if there were a vaginal delivery, okay, now because suppose forceps has been applied, there's a lot of pressure, a hematoma can occur high up here, which cannot be visualized from the lower genital tract. If you were to do a PS, you'll not be able to see the hematoma here, which is why when we talk about definition of PPH, even if the bleeding externally is not more than 500 ml after vaginal delivery or more than 1 liter after your C-section, a hematoma can actually form inside, okay, and the patient can be hemodynamically unstable. She will have increased heart rate, increased respiratory rate, decreased SpO2, decreased blood pressure. So this is why definition of PPH also includes those particular criteria. Okay, and this is the reason why we are predisposed. The vascular supply is so rich that, which is why there can be a lot of blood loss. So this is an actual picture from yesterday. I was called into OT. My team, this particular patient was referred from your Nongstoin Civil Hospital. Okay, a very interesting case. So there was ruptured uterus. Now, when I said about the differences between your ruptured uterus and your atonic uterus, your traumatic and your atonic, this particular patient had ruptured uterus, and this is a real picture. That is me in the white glove. My SR is the other one. So what actually happened was this patient had a first delivery by C-section followed by 2 VBACs, meaning after her first delivery, she had 2 C-sections. This patient was referred from Nongstoin with ruptured uterus. When she came to us, her pulse rate was 200. Again, it fits the definition, right? And then her bladder was full of bloody urine. She had hematuria when she came in because there was obstruction lower down, okay? But the uterus was well contracted. So what we did is that in such cases, either we have to take out the uterus, but in this case, she was not bleeding that much, was well controlled at this time, so we had just repaired the ruptured site. Now, but sadly for this patient, her bladder was also involved because the lower edges were very ragged and it went to involve the bladder, so we had to call in the urologist. It took forever, and on top of which this patient was COVID positive, so it was a very difficult surgery for us. Okay, so this is real picture from just last night. So now the baby was already outside the uterus. Can you believe it? So the rupture was full blown, okay? That the baby was already in the abdominal cavity. It was no longer inside the uterus. Okay, so I think I've already taken a class on ruptured uterus, and I spoke about how ruptured uterus can be complete rupture. It can just be just starting off, just scar adhesions can be there. In this case, the rupture was full blown. By this time, when I had asked my postgrad to take this picture, I was already halfway through suturing the uterus, but it was actually pretty bad from this end going up to the other end. Okay, and then when we had opened up the abdomen, the baby, the placenta, everything was outside the uterus, was lying in the abdominal cavity. Obviously the baby was already an intrauterine. That was really sad. It was a 3.6 kg baby, but was already in the abdominal cavity. Okay, so which is why I say this particular topic is so important, because we see it day in and day out. So this particular patient, she fits everything for ruptured uterus and for traumatic PPH, the predisposing conditions. G4, higher order pregnancy, right? She's multiparity. Previous one LSCS, like I said, traumatic PPH, any previous LSCS cesarean section can predispose to having a ruptured uterus. Okay, baby weight 3.6 kgs. Okay, the normal cutoff we take in India is 2.5. 3.6 is a particularly good weight. So all these fit into it. And the sad thing is that the patient went to labor on the 1st of October at 7 p.m. And she came to us yesterday evening. We opened her up at about 8:30 last night, and it was a little bit too late. We could not save the baby. Okay, so it's something very, very common. So when we talk about trauma, like I said, it can involve anything. Hematoma is very important. Emergency, site to be repaired right away. Now this patient, you can just imagine, 1st of October, 7 p.m. at night was when she started going to labor. According to her and her relatives, she suddenly stopped having contractions. Why? Because everything has given way. Okay. Now, once the baby has come out of the uterus, it's lying in the abdominal cavity, there's no contraction whatsoever. She had loss of fetal movement. I think that was the time when she lost her baby. Okay. And then what happened was that we lost a lot of time, because from Nongstoin she came to Ganesh Das referred her to here, and it was a little bit too late. Okay, so 7 p.m. on the 1st, and we opened her up yesterday. She came to us late evening. We were able to open her up at 8 p.m. Okay, so now such cases, when they're diagnosed, ideally, immediately, patients should undergo laparotomy, and the site is to be repaired, like what I did last night. Or if that is not feasible, there's too much of hemorrhage, then a hysterectomy is to be done. Okay. So the third T, so we finish with the first and second T. The third T is tissue. This is usually because of your placental fragments, which are retained in your uterine cavity. Placenta accreta or your adherent placenta can be one of the main causes. Okay, another thing is that traction on umbilical cord. This can also affect. Because when you do traction, which is not controlled, what happens is that bits and pieces of the placenta can be left behind, and that retained placenta will prevent or will hamper contraction, and this can lead to uterine atony. So prevention is to make sure the placenta comes out intact. How do we do that? Control cord traction. I'll talk about that a little later. And if in case we diagnose any retained tissue, we should remove it as soon as possible, because these type of patients may not present as primary postpartum hemorrhage. They may actually come back to you later with secondary or late postpartum hemorrhage. Okay, the fourth and last is your thrombin. There are various conditions that can lead to deranged your coagulation profile. It can be genetic, it can be obstetrical causes like your eclampsia, your placental abruption, and the finally the thing that actually causes a big problem for us and which actually leads to postpartum hemorrhage is your DIC, or your disseminated intravascular coagulation. And how does this affect? So it prevents clot formation, and this can lead to your postpartum hemorrhage. So we talk about the 40s. So it's very, very important. Postpartum hemorrhage is an obstetric emergency. It's very important for us to arrange blood. As soon as the patient comes, the first thing we do is put 2 IV, large bore IV cannulas in situ. Again, a very, very favorite questions among the examiners. 2 large bore IV cannulas, push IV fluids, and blood products are to be kept ready and transfused accordingly. The patient who came yesterday had a component of everything. She was in DIC as well. Her coagulation profile was deranged. We had to transfuse FFPs, or your fresh frozen plasmas, for her. Okay, so the more the delay, like this patient, I believe it was 24 hours by the time we saw her. So there was a huge delay. And because of that, DIC had already set in. So when we look at the management, again, a very, very important slide. This is the second important slide from today's class. First important slide were the 40s of PPH. If you remember this slide, you're good to go. Okay, you remember 40s and you remember this, and then you're good to go. So management, the mnemonic is hemostasis, HAEMOSTASIS. So H is for help. Okay, whenever a patient comes to you with postpartum hemorrhage, the first thing you do is ask for help. So like yesterday, when the patient came to casualty, my postgraduate saw her. My postgraduate informed or asked for help from a senior resident. The senior resident immediately called me up. Okay, I was a consultant on call, so I was called for help. So this is very important. You assess. What did I say? Vital signs. You look at her pulse rate. Yesterday's patient who came with ruptured uterus, her pulse rate was 200. Okay, that was how high it was. Look at blood pressure, you look at respiratory rate, you look at the amount of blood loss, okay? And then you try to resuscitate. When I say resuscitate, 2 large IV bore cannulas, you push in your colloids, your fluids, your IV fluids, okay? That is your basic or initial resuscitation. Then you establish etiology. You try to see whether the PPH is because of your tone, trauma, tissue, or your thrombin, your 40s. That's how you do it. Then you ensure availability of blood. You arrange for blood. Usually we always arrange for packed cell volume, your fresh frozen plasma and platelets. And ecobolics. What do I mean by these? Your uterine tonics. The commonly used ones here are your oxytocin, your mesopros, and your carbopros. Okay, so that is what we do. Then M is for massage uterus. O is for oxytocin infusion, your prostaglandins. Okay, so this is your medical management. O. Stasis is all from S. So you just remember hemo. Till hemo, it is conservative management, non-surgical management. Hemo is non-surgical management. Stasis is surgical management. S, if all of these you've done and nothing has happened, you shift the patient to your operating theater, exclude retained products and trauma, and you do bimanual compression. T is your uterine tamponade or your uterine packing. A is apply compression sutures. I'll come to that a bit later. The most commonly used one is your B-Lynch. If that doesn't work, so this is very easy. If you remember this flow chart, this is actually how it goes. Okay, H, then A, then E. Okay, this is how it goes. So you apply compression sutures. If this doesn't work, you do systematic pelvic dysvascularization. And this is also a very important MCQ question. When you talk about systemic pelvic devascularization, you start with your uterine arteries. If that doesn't work, if the bleeding doesn't stop, you go to your ovarian. If that doesn't stop, the last resort is to do your internal iliac artery ligation. You remember the earlier picture I showed you about the vascularity of the uterus? So that is why you need to ligate these vessels. Okay, if this doesn't work, then you do your uterine artery embolization in centers where it's available. Uterine artery embolization is not done everywhere. And your last resort, your non-conservative surgical management or your radical surgical management would include a hysterectomy, either subtotal, which is preferred, or your total abdominal hysterectomy. So this, if you remember this flow chart, you remember this mnemonic, you're good to go. So briefly talking about your B-Lynch, okay, so your B-Lynch comes here, compression sutures. So what happens is that we just tie 2 sutures around the uterus. We compress that because you see the uterus doesn't have any tonicity, so it's lack its tone. So you need to compress it. You apply these sutures, and this is how it looks like after you've applied the suture. More often than not, this helps a lot, and there's no other further management required. The other types, it's just good to know the name. One is your B-Lynch, your modified B-Lynch, your Hayman uterine compression suture, your Cho's multiple square suture, and then closer home you have something called global stitch by Guna Shela. Okay, so these are the type of compression sutures that you would do. Now this is especially, you try to do this method in the patient who is, say, a primary or second gravida, right? And the multi-gravida who's already had 3-4 children, you would like to go for hysterectomy straight away. Stepwise devascularization. First, what would you ligate? The uterine artery. Okay. Second, if that doesn't work, you'd ligate the ovarian. That's why it's called systemic. First, you do the uterine. If that doesn't work, you ligate the ovarian. If that doesn't work, then your last resort would do the internal iliac artery ligation. Okay, this is again a very, very important slide. What is AMTSL? So how do we prevent postpartum hemorrhage? So sometimes in your short note, they will just tell you to write AMTSL. So AMTSL stands for Active Management of the Third Stage of Labor. This includes 3 steps. First is to give oxytocin. How much? Very important, again, a very important Viva question in your final exams. 10 units IM, oxytocin. Okay, when is it supposed to be given? After childbirth. Mind you, it's not after delivery of the placenta, it's after childbirth. Second is your control cord traction. So when I say control cord traction, as you can see in this figure here, with the right hand, the obstetrician will pull out the cord. Okay, after you've seen that the placenta is separated, how do you know that placenta is separated? There'll be a gush of blood. So with your right hand, you pull on the cord. With the left hand, you will do an upward and downwards maneuver so that there'll be no inversion of the uterus. That is what is known by controlled. You control the cord with your right hand, and with your left hand, you're going to push the uterus upwards and downwards. So this is called control cord traction. And the third one is massage the uterus. Again, a very important question. You do not do a bimanual massage. You just do a per abdominal uterine massage. So this is again a very important MCQ question. AMTSL includes all of the following except. So these are the things: 10 units IM oxytocin, CCT or control cord traction, and uterine massage. And out of all these 3, 10 units oxytocin IM is the most important step. And studies have shown that AMTSL, or active management of third stage of labor, has a drastic effect on reduction of your postpartum hemorrhage. So routinely, all patients, we have to do active management of third stage of labor. Another very important thing, not part of AMTSL, but it's very important that even after delivery, every 15 minutes, the abdomen is to be palpated to make sure that it's contracted, and a per vaginal examination, per vaginal as in local examination, inspection is to be done to see if there's any increase in bleeding per vaginal. Okay, so summary: postpartum hemorrhage is hemorrhage that happens after giving birth. It is the number one reason for maternal morbidity and death, at least in India. Okay, it accounts for 25% of your maternal morbidity, right? So it's defined as blood loss of more than 500 ml after vaginal delivery, or more than 1,000 ml after C-section, or if there's any changes in the mother's heart rate, blood pressure, or your SpO2. Okay, so if there's any of the patient is hemodynamically stable, it could be because she has internal hemorrhage. She could have an internal hematoma which cannot be visualized. So even if she has these following changes, she will still be labeled as postpartum hemorrhage. Or there's a decrease in more than 10% of your hematocrit. Primary postpartum hemorrhage occurs within 24 hours of delivery. secondary or late postpartum hemorrhage occurs after 24 hours of delivery. The usual causes for secondary is usually your tissue. When there's any retained tissue, so the third T is the usual cause of your secondary or late hemorrhage. So what are the causes of PPH? The four T's: tone tissue, tone, trauma, tissue, and thrombin. And management of PPH, you just follow your mnemonic hemostasis and you're good to go.